All right, thank you guys so much for letting me tune into Noom Report and letting me talk about a topic that I really care about. So for those of you that don't know me, I am one of the internal medicine clinical pharmacists that usually rounds with one of the medicine teams. If I'm not rounding, then I'm usually precepting one of our pharmacy residents that is rounding with one of the colored teams. A little bit of background about me. I did my undergraduate and pharmacy school at Auburn University, and I graduated in 2017. After pharmacy school, I went on to do both a PGY1 and a PGY2 internal medicine focused residency at Indiana University Health. And my second year was actually a co-funded position with Butler's Pharmacy School that focused on a cardiology and academia emphasis. So hence why I'm talking to you guys a little bit about heart failure today. And here are my practice interests. I have on here heart failure. I love acute coronary syndromes, and obviously anticoagulation is a big thing that we are monitoring as pharmacists. So I'm happy to be here talking to you guys about this topic. And if you have any questions, I have to toggle back and forth to get to the chat, but feel free to kind of speak up, or I'll go back and forth to the chat every once in a while. So our objectives today are to give a brief overview of heart failure pathophysiology as it relates to our pharmacotherapy options. After that, we're going to discuss some of our guideline-directed medical therapies and other agents that are indicated to optimize and reduce our risk of both morbidity, mortality, and sometimes even symptom relief. And then finally, towards the end, we're going to evaluate some of our literature related to newer therapies and indications for medications to help further optimize our patients with heart failure. So to begin with a little bit of background, we can broadly categorize or define heart failure as any structural or functional cardiac disorder that leads to an impaired ventricular pumping or filling. This is a pretty significant comorbidity of patients because they often have a lot of other risk factors and comorbidities going on, and it can affect up to 6 million Americans that we'll see throughout the year, and oftentimes they are one of the reasons for our hospitalization. So it's estimated that it's the primary reason for discharge in 1 million hospitalizations per year, and it's a secondary discharge diagnosis in about 2 million hospitalizations every year. It does play or have a pretty big hand in mortality, so up to 4 to 12% of patients. This can lead to some of their inpatient mortality, and up to 25% in our higher risk groups. And another thing that we think about, especially from a pharmacy standpoint, is healthcare costs and drug-related costs. So this is estimated to be about 1 to 2% of our U.S. healthcare budget. So it wouldn't be talking about this without talking about some of our risk factors and causes. So heart failure is kind of a complex pathophysiological condition, and it is complicated by a number of different risk factors. Some of the most predominant ones that you have probably seen on your patients are hypertension, a lot of our metabolic diseases such as diabetes, other heart diseases such as coronary artery disease, acute coronary syndromes, and any valvular or arrhythmias can also precipitate or lead to heart failure. Thyroid diseases, specifically hypothyroidism, can exacerbate this as well as other structural components such as non-ischemic cardiomyopathy or dilated cardiomyopathies, stress-induced cardiomyopathies, as well as different viral or infectious myocarditis can come into play. And a lot of our patients will see even cardiotoxins can lead to a heart failure diagnosis. And some of the more common ones that can lead to this would be alcohol-induced or cocaine-induced. So to begin with, I wanted to kind of touch on some of the important key terms and a little bit of the pathophysiology as it relates to heart failure so that we can really hone in on some of our pharmacotherapy targets. So some of the 3 big terms that I think about when we're trying to target heart failure treatments would be cardiac output, preload, and afterload. So cardiac output is essentially a measure of contractility, and this can be measured looking at our heart rate multiplied by our stroke volume. And it's also important to remember that cardiac output is a component of our overall blood pressure if we multiply that by our systemic vascular resistance. Another component that I mentioned was preload, so this is our filling pressures or the pressure at the end of diastole in the heart. And then also we have our afterload, which is the force or the resistance that the heart is beating against or forcing blood out against. So within these three terms, these are going to be kind of the things that are going to be modified within heart failure and within our targets as it relates to drug therapy. We do have a couple of compensatory mechanisms that help on the short-term end to help the heart function when we have deleterious effects. So if you guys remember, the Frank-Starling principle is a relationship between left ventricular end diastolic pressure or preload as it relates to stroke volume. So theoretically, as we increase our preload or our left ventricular end diastolic volume, our stroke volume should concomitantly increase to kind of counter any decreases in cardiac output. Additionally, we have neurohormonal changes or responses in relation to decreased cardiac output or changes in cardiac function. That's related to our sympathetic activation. We also have the renin-angiotensin-aldosterone system or RAS activation. And then finally, we have natriuretic peptide release that kind of compensates for anything going on that is negative in relation to cardiac function. So some of the short-term effects that I pretty much already mentioned, anytime the heart senses a decrease in cardiac output, it's going to try to compensate by increasing the filling pressure or the preload, which in turn will intrinsically increase our stroke volume. You'll again get activation of your sympathetic system, which will lead to the release of catecholamines, specifically norepinephrine, that will bind to our beta receptors and increase heart rate. You'll also have activation of the RAS system, which also in and of itself, due to the angiotensin 1 effects, will increase sympathetic response. You'll lead to sodium and water retention and also vasoconstriction. So all in all, short term in an otherwise healthy heart or in the early stages of heart failure, you should get an increase in cardiac output. However, in longer term heart failure or further down the road, more and more cardiac dysfunction, and as you have more cardiomyocytes die off, it's going to lead to detrimental or deleterious effects and excessive strain due to this prolonged compensatory response. So overactivation of the RAS and sympathetic system over time is going to lead to significant sodium and water retention that the body just cannot counter-respond to. You're also going to have significant vasoconstriction, and this is also going to lead to some of those ventricular remodeling effects that we know happen and occur in heart failure patients. Additionally, as I mentioned on the first slide, we do have kind of a natural response to some of the sodium and water retention or in states of hypervolemia. The cardiac tissue actually does release B-type natriuretic peptides, which is released from cardiac tissue in hypervolemic states to help with vasodilation, natriuresis, and diuresis. So it kind of tries to counter the effect. So that's why in a lot of our exacerbation states, you're going to see an elevated BMP. And then additionally, unfortunately, the Frank-Starling principle can only go so far. You can only get so much stress as related to the preload to where the stroke volume can be compensated. So over time, due to the fibrosis and the hypertrophy, an increase in preload is not necessarily going to result in the same increase in stroke volume. So that's a big overview of some of our big targets that we'll be talking about as it relates to pharmacotherapy. So overall, this is what a heart failure patient is typically going to present as. They're going to have an increased preload, an increased afterload, and decreased cardiac output. So to go into some of the different ways we classify heart failure, the first that I think about is via ejection fraction. So we kind of have three categories that we can put them in. We have our preserved ejection fraction or diastolic dysfunction, which is an ejection fraction of greater than 50%. Then we have probably more commonly in what we will talk about and focus on in this session is our reduced ejection fraction, which is an ejection fraction of less than 40. This is characterized by our systolic dysfunction, and it's primarily a pumping problem. And then we have this middle classification here that you may have heard called a number of different names, mid-range, moderately reduced, or mildly recovered. And this is kind of this clinically gray area of 40 to 50%. But for the focuses of this presentation, predominantly due to the information and the trial data that we have related to medications, we'll be focusing on reduced ejection fraction therapies. Additionally, we do have staging as far as functional classification, and one thing to mention here is this is predominantly driven by a patient's symptoms, and patients can move fluidly between these classifications throughout their diagnosis. So to have a functional class of 1, usually this represents patients that are not symptomatic with normal activity. Functional class 2, and as we move down these, you notice more and more symptoms with less activity. So these patients may be comfortable at rest with slight limitations when they start to get active. Our class 3 patients may still be comfortable at rest, but they are significantly limited when they try to do any sort of physical activity by their heart failure symptoms. And then finally are our patients that are symptomatic pretty much at baseline all the time, regardless of their level of activity. So this is important to remember because some of our medication indications and how they're studied relate to some of these specific functional classifications. And then finally, we have staging based on the ACC-AHA classification. So these are letters A through D. Our A patients are basically only our patients that have risk factors for heart failure. So they do not get any sort of functional classification according to the New York Heart Association. Group B here is patients that are identified and diagnosed with heart disease or heart failure based on an echo. So they have structural disease, but they may or may not have, they won't have symptoms at this point in time. So they are given a functional classification of 1. C are probably our most frequent flyers or common presentations that we'll see both on the inpatient and outpatient side when we're managing these patients. So these are our patients that have structural disease, but they either have previous or current symptoms, and they can fall anywhere within the functional classification. And then last but not least, we have our stage D patients, which these are typically our refractory heart failure patients that have been on guideline-directed medical therapy, but have failed or have continued to decompensate and get worse and worse and now require special interventions such as left ventricular assist device placement, and even referral for transplants. And so these are generally our patients that have symptoms at rest. So I will start with a little bit of a pop quiz related to pharmacotherapy since I'm a pharmacist and this is what I typically look at every single day. So just if you guys want to chime in either verbally or in the chat, that's fine with me. So which medication should generally be avoided in patients with heart failure? A, amiodarone, B, amlodipine, C, dofetilide, or D, ibuprofen. All right, so you guys that said D, this is probably the most accurate answer, and we will go into some of the reasons why and some of the ones that I look for when I'm looking at inpatient admissions, screening their med list, inpatient and discharge. So NSAIDs are probably better to be avoided in heart failure patients because they can lead to pretty significant sodium and water retention, which is going to counter everything that we're going against in relation to some of our therapies. So it can make their symptoms worse. So it's generally recommended to go to other agents such as Tylenol if you need it for pain relief. That would generally be a better therapy for these patients. Other things that we look for are a diabetes medication. TZDs have shown to lead to heart failure exacerbations even in patients that have not been shown to have heart failure and can lead to pretty significant edema. That was seen in a number of the trials when these drugs came to the market. So it has a black box warning for patients with heart failure. So we want to avoid these. And then in addition, some of our negative inotropic agents, specifically our non-DHP calcium channel blockers, so verapamil and diltiazem, these can be harmful in our patients with heart failure. Same goes with most of our antiarrhythmics due to the negative inotropic effect. So some of our class 1 and our other class 3 antiarrhythmics other than dofetilide and amiodarone, we want to avoid. So if you look at AFib guidelines, these are the two that are listed under patients with concomitant heart failure that you can kind of see neutral effects to that are deemed to be safe. So if you're looking to go away from rate control to more rhythm control, your options are kind of limited in heart failure patients from an antiarrhythmic standpoint. And then finally, psilocybin is contraindicated in patients with functional class 3 and 4 because it actually had a mortality associated with it. So We don't see this drug very much, but it is something to consider in our patients with intermittent claudication if this is something that they truly need or not. And then I put some medications just to use in caution. So these are kind of scenario-based and on a case-by-case situation, especially meds that we may see commonly inpatient or the outpatient world. So metformin just carries a risk to monitor in heart failure patients, and we probably want to be cautious in our patients that come in with an acute decompensation, and that's just due to the risk for development of lactic acidosis. So a lot of times we'll hold this inpatient until they're stable anyway, so that's just something to remember for your patients that have metformin at home, that it can increase your risk for lactic acidosis. Citalopram and saxagliptin can be shown to increase myocardial dysfunction, so that's why they're on this list. Pregabalin is a warning just because it can lead to pretty significant peripheral edema and weight gain, so that may make it harder for patients to determine whether they're in more of an exacerbation or if this is drug-induced. And then a lot of our over-the-counter cough and cold medications and amphetamines lead to sympathetic stimulation and release of catecholamines or binding to those receptors, which would be kind of counterintuitive in these patients. So we want to advise them to think of other options just to kind of mitigate some of their risk. So now we'll kind of move more into the pharmacotherapy, and I've kind of organized these by stages and some of the drugs as a whole. So all across the board for all of these stages, we want to always optimize their risk factors and comorbidities according to guidelines. When we move more to B and beyond, this is where we get more of our drug therapies that are indicated. So this is where you can start adding on your ACEs and ARBs in addition to beta blockers. Stage C and D is where we get a bunch of our add-on agents for further reduction in morbidity and mortality. So for most of this discussion, we're going to be focusing on the stage C recommendation, since this is where the majority of our pharmacotherapy comes into play. So overall, our goals of therapy, we want to make sure that we're controlling heart failure symptoms with our medications and our diet. We want to help improve their quality of life, make them live as long as they possibly can, and reduce their hospitalizations. And that's all something we can do through education and some of our pharmacotherapy. I listed these here just for your reference. Some of these guidelines are actually pretty out of date, especially with the ever-changing world of cardiac literature that is constantly updating pretty much monthly at this point. So our most recent guidelines are from 2013. That's the whole set. We did have a consensus update in 2017 that mainly focused on some new recommendations in relation to some of the newer agents that came on the market that we'll discuss. And this is directly related to probably stage C heart failure. So now we'll get into some of the chronic management, and I'll start talking about some of the pharmacotherapy here. So I wanted to include a very, very brief slide on preserved ejection fraction because a lot of our pharmacotherapy evidence is not really indicated, or at least has shown a improved mortality associated for our patients with an EF of greater than 50%. So that's something to keep in mind. What guidelines actually recommend doing is managing comorbidities and optimizing the patients from those standpoints. So targeting our blood pressures less than 130/80. It's reasonable to consider some of our heart failure therapies as management of these comorbidities, such as ACE, ARBs, and beta blockers. And then there is some limited data for both the Aldosterone Receptor Antagonists and the Angiotensin Receptor Blockers that in small subgroups or secondary endpoints of clinical trials may have shown some decreased hospitalizations. And then obviously for our patients that come in with decompensation or have symptoms of heart failure, then we can prescribe diuretics for symptom relief. So here's a summary of some of our pharmacotherapy targets that we'll move throughout this presentation. Some of our RAS blocking agents are listed there. These are going to be a lot of our first line and or switching agents that we're going to kind of add on to further reduce morbidity and mortality. Blocking our sympathetic nervous system is going to be done through our beta blockers. The ARNIs have the additional benefit of enhancing the natriuretic peptide positive response in heart failure. And then we have heart rate modulators, and then some of our vasodilation and oxidative stress modulation. So the first medication, which is one of the cornerstones in heart failure, are our Angiotensin-Converting Enzyme Inhibitors, or ACE inhibitors. And these should be started in all patients with either prior or current symptoms, and that's because they've been shown to reduce both morbidity and mortality in all of these patients. I've listed on the slide here all the agents that are listed in guidelines with the maximum doses, the frequency, and then the mean doses achieved in the clinical trials. And as we'll move through this presentation, it really is important for these first-line agents that we try to get them optimized on a max tolerated dose. So it's important to remember that our ACE inhibitors are going to both decrease our preload and afterload, which is going to in turn improve our left ventricular function. Another thing to remember is that this is a class effect, so pick one that's either preferred on the patient insurance, is easy for the patient to take, or they've tolerated in the past, and that should be good to go from an optimization standpoint from the ACE inhibitor. With these medications, you do want to start at a low dose and titrate just about every 2 weeks. If they're in the hospital, you can do a little bit more rapid titration due to our ability to monitor patients more closely. And you do want to try to target it to the clinical trial dose or the max tolerated doses, because it has been shown through the literature that we have that higher doses are more related to better reduction in morbidity and mortality. So some side effects that we want to think about are obviously hypotension, an increase in serum creatinine, which is due to the vasodilation of the efferent arteriole. So we are going to expect a rise, but any rise greater than 30%, we should probably discontinue and reduce our dose. So that's something that we look for when ACEs are a new start in a patient. Another concern that we're looking for is hyperkalemia, cough due to the bradykinin production there, and then angioedema is a potential risk with this medication, though the overall incidence is relatively low of less than 1%. This has been a little bit more associated with African American patients, so one of the next medication classes that we talk to may be a potential option for those patients. So some clinical pearls to continue with this. We obviously want to monitor our renal function, so watching for creatinine clearances less than 30 or serum creatinine rise greater than 30, and that's just because these patients that have renal insufficiency may be at a greater risk for hyperkalemia. So a potassium greater than 5, we may want to stop, hold our doses, or even reduce our doses. We also want to monitor blood pressure, and then our patients with renal artery stenosis, they're at greater risk for renal insufficiency and hyperkalemia as well. So specifically our bilateral renal artery stenosis, they have the highest risk factors for this. And then contraindications here is any patient that has experienced angioedema. This is unfortunately a side effect that can occur at any point during the course of an ACE treatment. So if it happens, you generally do not want to ever administer an ACE inhibitor again. And then it does have a contraindication for pregnancy. So moving into one of our next agents is our angiotensin receptor blockers, or ARBs. And this, again, is indicated in all of our patients that have either contraindications to or are intolerant of ACE inhibitors, and that's because they've also been shown to reduce morbidity and mortality. So I've listed the 3 agents there with their doses for your reference. Some clinical pearls related to these. Again, we want to start low and titrate to the max tolerated doses. These, just from anecdotal experience and some of the literature out there, patients generally experience better tolerability of these compared to ACE inhibitors, but they may or may not be a little bit more costly, so that may be something to consider in these patients. It does have a lower risk of angioedema. There are case reports of it, but the risk overall is relatively much lower compared to ACE inhibitors, so you want to consider this cautiously in patients with an ACE inhibitor that had angioedema. The cross-reactivity is less than 2.5%, so it's kind of a risk-benefit decision at that point. This is also an alternative to ACE inhibitors in the setting of cough because it doesn't mediate that bradykinin production, and then some of the same monitoring applies that we talked about for ACE inhibitors. And then another little caveat here, just due to harm that we've seen for patients, is that you don't want to triple RAS block these agents, so adding on an angiotensin-2 receptor blocker, our ACE inhibitors, and aldosterone blockers. This has led to pretty significant renal dysfunction and hyperkalemia. So moving into one of our newer agents that was FDA approved in 2015 is Entresto, or our angiotensin receptor Neprilysin inhibitor. And this kind of has a novel mechanism of action, and it is actually indicated in patients as a replacement to our ACE inhibitor or ARB therapies to further reduce morbidity and mortality. So some caveats to this is that they need to be, according to the package insert, fall within a functional classification of 2 through 4. The guidelines specifically say 2 through 3, but some of our clinical data led to the package insert labeling, extending that through class 4. And then obviously they would have had to tolerate it, either an ACE inhibitor or an ARB. So the dosing here is included. This is a twice daily medication that we want to try to get to target doses here. Initial doses are typically 49-51 milligrams twice a day, but there is a caveat for initiating at the lower dose of 24-26 milligrams, and that's for patients that have either been on a low dose of an ACE or an ARB or are somehow RAS naive, have impaired kidney function or hepatic function, or the elderly population, just due to the risk of side effects. So like I mentioned, this is a novel mechanism of action. We have valsartan, which is an ARB, and so as we talked about, this inhibits the negative effects of angiotensin II, so that vasoconstriction, increased sympathetic response, and sodium and water retention. However, like I mentioned, BMP actually plays a beneficial role in heart failure by decreasing some of the sodium and water retention, leading to natriuresis and diuresis. However, there is an enzyme, Neprilysin, that will degrade BMP. So sacubitril was invented as a Neprilysin inhibitor to inhibit the breakdown of BMP, so we maintain some of those positive effects from BMP. So it kind of hits the RAS cascade and then the BMP, leading to the positive effects of both of those. So where we get this information is from the Paradigm trial, which looked at sacubitril valsartan titrated to the max dose compared to actually an active placebo group or an active comparator group of enalapril, 10 milligrams twice a day, which again, this is clinical trial dosing that we saw the benefit in. To be included in this study, patients had to have evidence of worsening heart failure as diagnosis of having a recent hospitalization and elevated BMP markers. They ended up collecting about 8,500 patients with an EF of less than 35%, functional classifications 2 through 4. An important caveat here is that to be included in the study, they had to already be prior to the study on a stable and max tolerated dose of an ACE inhibitor or an ARB plus a beta blocker. And there was obviously a washout period when they were randomized into these two arms. Looking at some of our baseline demographics, so the patients were predominantly 64 years old, 66% Caucasian, and just about 80% male. The median ejection fraction was about 30%, and most of the patients had a functional classification of 2. For their concomitant heart failure medications, most of the patients were on a beta blocker, and like I mentioned, they all had to be on an ACE or an ARB as well prior to this. About half of them were on an aldosterone receptor antagonist. Most of them were on diuretics, and about a third of them were on digoxin. So for the outcomes, they were actually looking at a composite endpoint of CV death or heart failure hospitalization, and they found that the sacubitril valsartan group had a 20% relative risk reduction in heart failure exacerbations or hospitalizations and CV death compared to an active comparator group with a number needed to treat of 22. So this was a pretty significant finding because this gives added benefit on top of standard heart failure therapy. Each of the sub-endpoints were also statistically significant and meaningful as well. So as a result, we now have Entresto on the market. Some clinical pearls related to this is that it does come in the 3 dosage forms so that we can titrate about every 2 to 4 weeks. One unique finding that I thought was interesting is that the valsartan component, you may have noticed, are lower doses compared to our standard individual component of valsartan, and it's actually more bioavailable, so that's the equivalent dosing listed on the slide there compared to our mono component there. Another thing to consider are costs. So because this has only been on the market for about 5 years, it's only brand name, and a lot of insurances are going to require prior authorization to deem it acceptable. And there are good patient assistance programs out there, but this may kind of be a barrier to starting this medication. Other things to consider, like all our other RAS blocking agents, we are going to see risk for hypotension and hyperkalemia at actually a higher incidence compared to just our ACEs and ARBs, and then renal dysfunction as well. Some contraindications here. We do still have a risk for angioedema. Pregnancy should not be used in pregnant patients, and then it does require a washout of 36 hours for any patient that was previously on an ACE inhibitor, and that is due to an increased risk of angioedema that they found in clinical trials with other agents. It actually conferred a 3-fold increased risk of angioedema. So that's why we have to incur at least the 36-hour washout period. So moving on to another one of our cornerstones of therapy, we have our beta blockers. This should be started in all heart failure patients with either current or prior symptoms to reduce morbidity and mortality. We have 3 agents that are indicated per guidelines: are bisoprolol, carvedilol, and the extended release metoprolol. So I put some considerations here. So the ones that are cardioselective, depending on the dose, are bisoprolol and metoprolol, and then are non-selective, so the ones that hit alpha and beta both, are carvedilol. So that's important to consider when we are trying to figure out which agent we want to start or continue in our patients. So for patients that have concomitant hypertension, it may be beneficial to start with carvedilol because it's also going to hit our alpha receptors and block that to infer more, therapy to help with their hypertension as well. So important clinical pearls here is that these are unfortunately not considered a class effect, and that's just due to other trials that they found even with metoprolol tartrate, to where they didn't find this survival benefit like they did in the ER formulations. We talked about selecting an agents based on patient characteristics, whether you need that alpha blockade. Our COPD patients, if we're worried about that, maybe getting more of a cardioselective one would come into mind. And then important here is that you want to initiate this as soon as heart failure diagnosis, as long as there are no contraindications to therapy, in addition to ACE or ARB therapy. Same with those therapies, we want to start low but gradually titrate to the max tolerated doses, again, due to the benefit we've seen in clinical trials. And because of this, we've actually seen the best CV outcomes with beta blockers and optimizing the sympathetic modulation. So if we have to give preference, at least from looking at the trial data and some of the guideline recommendations, it does give preference to trying to titrate beta blockers to the max tolerated doses if you're limited by side effects. We also want to avoid abrupt withdrawal because this can potentially lead to clinical deterioration. And because they can potentially lead to some fluid retention, these are often co-prescribed with diuretics. So some clinical pearls here. So side effects, we're obviously going to monitor for hypotension, especially with carvedilol and at higher doses of our cardioselective agents as they start spilling over into the other receptors. Dizziness, fatigue, and lethargy are a common complaint that patients really complain about, but this is important to kind of counsel them that they're going to be able to overcome this and get better with the medication, so the side effect starts to become more tolerable over time. Bradycardia obviously is something that we're going to be watching for, and then fluid retention, which we're going to be prescribing diuretics to help take care of as well. So contraindications to therapy would be a decompensated state that requires inotropes. So our patients that are hemodynamically unstable, beta blockers may not be the best idea at this time. Any sort of AV block, specifically third-degree blocks or severe bradycardia, thick sinus syndrome, and then cardiogenic shock, and then severe hepatic impairment with carvedilol. Moving on to some of our add-on therapies. So we have our aldosterone receptor antagonists, which include spironolactone and eplerenone. These are added on to select patients to further reduce morbidity and mortality. They are indicated in a certain subset of patients, so those patients that have an ejection fraction of less than or equal to 35% and also fall within the functional classes of 2 to 4. You can also consider these in patients that have a prior MI with an ejection fraction of less than or equal to 40 that either have current heart failure or prior heart failure symptoms plus or minus diabetes. So these are the patients that it was specifically studied in clinical trials and where they found that that benefit has come into play. So I've included our dosing here and some of the dose adjustments, which is going to be related to a patient's kidney function and their potassium level. So there are some strategies to help kind of mitigate this risk and adjust our doses to reduce our risk of hyperkalemia. So some strategies include decreasing the dose all the way down to 12.5 milligrams of our spironolactone or 25 of eplerenone, and you can even consider every other day dosing to try to get these on board. Some considerations with these agents would be that eplerenone is a little more selective, so it may have some lower risk of adverse drug reactions. So we're going to have less effects as far as gynecomastia. So patients that complain of those symptoms, you can consider switching to eplerenone. We also want to monitor our potassium levels and serum creatinine both at initiation and throughout the course of our therapy. So we want to wait until their creatinine falls to less than 2.5 in men or less than 2 in women, and their potassium is less than 5 prior to initiation, and then watching for rises of that as we adjust therapy. So in order to minimize some of our risk for hyperkalemia, there's a couple of different strategies that we have. If it rises greater than 5.5, you want to consider holding the dose and initiating at a lower dose, as I mentioned before. We also want to limit and adjust some of our concomitant agents, so we can reduce some of the doses of our other RAS blocking agents to confer a lower risk, and obviously avoiding triple RAS blockade. You also want to look for other sources that could be leading to the rise in potassium. So if a patient is also concomitantly prescribed diuretics and they're on potassium supplements and you start an ARA and their potassium starts rising, it may be worth addressing the potassium supplementation, whether you need to stop it or reduce the dose. And then also educating on a low potassium diet. So some things that I think patients don't realize is they're also on a low sodium diet. So a lot of our sodium substitutes have potassium chloride in it. So that's important for them to kind of look at the bottles when they're looking at things like Mrs. Dash or other supplements for salt. So educating them is a real important component of holistic care. And then finally, we want to watch their renal function. So the highest risk in clinical trials for developing hyperkalemia were in our elderly patients with impaired renal function. So making sure that we know what their creatinine clearance is and avoiding other nephrotoxins can help reduce our risk. Moving into another add-on agent, we have our Isosorbide Dinitrate with hydralazine. This is, again, another niche patient population that we can add on for patients to further reduce morbidity and mortality. And how this was studied was in patients that were on optimal doses of ACE or ARB plus a beta blocker, had New York Heart Association functional classification of 3 through 4, and the primary benefit was seen in African American patients. So we can add it on to these agents to further reduce morbidity and mortality. We can also consider it as a reasonable replacement to some of our RAS blocking agents to reduce morbidity and mortality. If patients have a drug intolerance, they have side effects such as renal insufficiency or hypotension. So this is available both as a fixed dose combination and as the mono components. So if patients have trouble affording the fixed dose combination, it's a little more expensive, you can prescribe the concomitant mono components. So important to remember here is that we're actually hitting vasodilation on both the venous and arterial vasculature, leading to a decrease in both preload and afterload. Other things that may be a barrier to patient care are adherence. So this is a 3 times a day medication that we're prescribing in patients that are already on, 3+ medications just for heart failure alone, not on top of the other medications for their comorbidities that they likely have. So it may be a barrier to them getting optimized or taking this medication as prescribed. We're also concerned for a nitrate-free interval, so this can be avoided, or you can incorporate this in by adding on the hydralazine at the same time, or just having the patient take their doses throughout the day and not taking a dose overnight. It's also significantly limited by adverse reactions, so up to 50% of patients experience headache, and about a third of them experience dizziness. So that's something to keep in mind that may be limiting for patients. And then another thing to consider is that it is contraindicated for patients that are on phosphodiesterase 5 inhibitors or guanylate cyclase stimulators. So that's something you want to make sure that you look over their medication list that there are no contraindications. We're not increasing their risk for hypotension. So here's just a summary slide that pulls a lot of the trial data for the morbidity and mortality reduction. You can see that it's pretty substantial number needed to treat for all of these. I put the ARNI data, so the Entresto data, that's there, and that's on top of the already established morbidity and mortality data that we get with some of our first-line therapies. So finally, we'll move into some of our adjunct agents. So diuretics are probably a cornerstone to heart failure therapies, and that's because
Dr. Wade, do you mind if I, before we move on to diuretics real quick, I think there was a question about the last section. Caleb Huber was wondering about if you would happen to know what the lifetime risk of drug-induced lupus is with hydralazine. One of the questions that we had in the chat.
Lifetime risk with hydralazine? Yeah. I would say it's overall low. I'll have to look up the specific, I guess, occurrence of that. But overall, I feel like I have not seen that occur very often. So,
yeah, we'll see if we can look into that. And then we were also just discussing, Caleb was wondering if we should, for our AIM clinic patients, I think potentially we have patients that would also benefit to switching to an ARNI, but we can work with our pharmacists in clinic for that too. So those are just a couple of things highlighted in the chat. Thank you.
Definitely. All right, so we'll continue with the diuretics here. Again, these are indicated for all patients that have symptoms to help relieve symptoms of volume overload. However, unfortunately, these do not confer any benefit for morbidity or mortality. I've included a diagram here of a nephron, and as you can see, these agents act all within at different components or different parts of the nephron that we can block to have potentially synergistic effects. So our cornerstones of therapy are probably going to be our loop diuretics that work within the loop of Henle, where about 25% of sodium is reabsorbed. So these are our agents bumetanide, furosemide, and torsemide. Differences between these, so furosemide is probably the lowest bioavailable agent. So for patients that have absorption issues, bumetanide and torsemide have about 80 to 100% bioavailability. So these may be better options for these patients. Additionally, dosing. So bumetanide and furosemide can be dosed, twice a day, whereas torsemide has a longer half-life. So these are typically dosed daily. Thiazide diuretics are usually add-on agents, so these are probably the second most common. The one that we see probably most commonly is metolazone. So I've included here some of our IV to PO conversions for your guys' reference as you consider our adjustments in our heart failure patients. So 40 milligrams of furosemide is equivalent to 1 milligram of bumetanide and 20 milligrams of torsemide. Torsemide is only available as a PO option. So I've included our IV conversion there. For furosemide, it is a 2-to-1 conversion, PO to IV. There are continuous infusions that are available for both furosemide and bumetanide. The dosing is included there, and these have some conflicting data as far as their effects being more beneficial in patients that are refractory to typical IV diuretics. They have been shown to increase urine output, but a lot of our trial data has not really shown decreased length of stay in the hospital. So it could be a consideration in some of our refractory patients, but it is usually not an agent that we jump to right away. So some clinical pearls, as I mentioned, loops are going to be our gold standard. And from a long-term perspective, we want to consider maintaining them on the lowest dose that's going to keep them dry or euvolemic. So as long as they are maintaining a healthy low sodium diet and no other things have changed, then the lowest tolerable dose is what we're going to try to keep them on. While loop diuretics maintain their efficacy when we have some renal impairment, some of our thiazides become less effective when creatinine clearance is less than 30, and that's just likely due to their site of action being further along in the nephron. So it usually requires much higher doses to potentially see a beneficial effects when you're considering your thiazides. Monitoring, the big thing that we're going to look at here is our electrolytes and renal function. So As you guys probably see on the inpatient world and even the outpatient world, we see significant depletion in our potassium, sodium, and magnesium. So we have to really be aggressive in replacing these in our patients that we're actively diuresing to get volume off. Some other things to consider are dry weights versus wet weights, monitoring those. That can help both titrate our meds on the inpatient and outpatient perspective. Urine output, if we're able to get it, I know that the ICUs are much better at collecting that than the floor. So if we can encourage getting accurate urine outputs on these patients that we're accurately diuresing, that would help kind of guide our therapies as well. Also monitoring for azotemia and hypotension. So when we think about exacerbation management, specifically even in the hospital setting, what the general rule of thumb is to increase their diuretic by 2 to 2.5 of their home regimen. And that is important to assess if they are adherent or not. So you want to ask them if they've been taking it or if they've missed doses, because that's going to help you determine a starting dose. So an easy way to think about it is if they're on 40 milligrams of furosemide at home, you can do the same IV dose, and that's going to be doubling their diuretic regimen. So for monitoring, in addition to some of our clinical signs and symptoms, if we're able to get urine output, you want to try to keep them net negative and potentially shoot for a goal of less than, or for getting off about 3 to 5 liters of urine output daily. But again, this is going to be patient specific and depend on response. So I will let you guys briefly, since we're kind of getting close to time, look at this patient scenario and chime in with potential therapies that you would kind of consider. So it's a 59-year-old male admitted for heart failure exacerbation and volume overload. He's on furosemide 80 BID at home. He says he's been adherent. We start him on 80 milligrams IV twice a day while inpatient, but unfortunately he's still very symptomatic and has had very minimal urine output. I've included his labs there, and all his other BMP is normal. So if you guys want to chime in and let me know what thoughts that you guys have for next steps.
We got a comment to add metolazone.
Okay.
Or
anything else?
Bladder scan. Another.
Okay.
Anyone else? Bumax as another addition to transition to.
Awesome. Okay,
or
great.
Increased Lasix frequency.
Perfect. Okay, so those are some great responses, and that I'll kind of touch on here. So one of the things that kind of comes up in some of our resistant patients is obviously diuretic resistance. So some things that come into mind are possible ceiling doses. So patients that are on long-term diuretics or are not responding to doses, typically doses greater than 160 to 200 milligrams, there is the thought that you will not see any additive benefit in diuresis at higher doses. There's also the breaking phenomenon to where you're not going to get adjunctive diuresis due to structural and functional changes within the nephron. But to kind of work up the diuretic resistance, there's a couple of different things you want to look at. So you want to, again, ask them about adherence, check on their diet. So if they're having a high sodium diet, that may be contributing to it. Other medications can lead to a picture of diuretic resistance. So being on NSAIDs or potentially even steroids can blunt the effects of diuretics. Any changes in kidney function, specifically decline, and then absorption issues. So some strategies, like you guys all mentioned, that we can do to overcome diuretic resistance. We can increase the dose or the frequency of the agent, or potentially change over to a new agent. So like going from the furosemide to the bumetanide, maybe we'll have better responses. You can consider IV diuretics or even potentially a continuous infusion if they're very refractory and you've exhausted all efforts. The other thing to consider, like you guys mentioned, adding metolazone is sequential nephron blockade. So we do get a synergistic effect by adding on a second agent with a different mechanism of action. So that's something to consider there, as well as salt restriction. So there are some less common or more investigational agents, such as ultrafiltration for our patients that are very refractory, low-dose dopamine, potentially Vaptans, and then newer on the market that we'll kind of touch on are SGLT2 inhibitors are kind of coming up in discussions. Moving on to some of our last line therapies that we'll breeze through pretty quickly. So ivabradine is also Corlinor. It was approved around the same time as Entresto, in 2015. This is an add-on agent to only reduce hospitalizations. So it has a very niche patient population that it is indicated in. So patients have to be both symptomatic and have stable heart failure, have a reduced ejection fraction less than 35%, already be on a beta blocker at a max tolerated dose or have a contraindication to a beta blocker, and then also be in sinus rhythm with a heart rate that is consistently above 70 beats per minute. This is a twice daily medication as well. And then this medication comes from the SHIFT study, which randomized patients to either receive placebo or ivabradine titrated to the target dose of 7.5 milligrams twice a day. It randomized just over 6,000 patients for about 23 months, and all the inclusion criteria reflect their guideline indications that I just mentioned on the previous slide. For baseline demographics, the ejection fraction was about 29%. We had about half of our patients being functional class 2 and half functional class 3. Concomitant medications, again, most of them were on a beta blocker. However, about only 26% of them were at the target dose. So that's something to consider as far as this drug's utility. Also, they should be on an ACE or an ARB, so about 85% of these patients were on that. Just over half are on an ARA, and then most were on diuretics as well. Outcomes, again, similarly to the Paradigm trial, they looked at the composite endpoint of CV death and hospitalization. They did find a significant difference with a relative risk reduction of about 18% in the ivabradine group. However, this was predominantly driven by the heart failure hospitalization component. So that's why it is only indicated for reducing hospitalization and does not right now have a labeled benefit for mortality reduction. So some things to think about: it does have a novel mechanism, so it actually works in the pacemaker cell, so it works on the sinoatrial node to inhibit the funny channels, and that's going to confer a decrease in heart rate without inotropic effect. The dose is interestingly titrated by heart rate and tolerability, so we're aiming for a goal of 50 to 60, and you can up or down titrate to try to maintain within that target heart rate range. Cost, again, is another consideration. It's only been on the market for 5 years. It's likely going to require a PA, and a lot of your pharmacies may or may not even carry it. So this is not one that we have on formulary here at ULH, unfortunately, and I have not seen a whole lot of patients on this medication as a whole. It does not really have any renal dose adjustments, but it should be avoided in AFib patients due to it being one of the side effects in up to 8% of patients. Other side effects that we're going to be watching for are bradycardia, and then it also has this interesting side effect of phosphines seen within the visual field. This medication should not be started in patients that have sick sinus syndrome or specifically AV nodal blocks, those that are on strong 3A4 inhibitors, and those with severe hepatic failure. And then finally, one of our kind of last line agents nowadays is digoxin. It actually was not even mentioned in any of our treatment algorithms in the Stage C 2017 consensus updates for heart failure management. The last mention of this was actually in the 2013 original guideline statement, where it could potentially be added on to reduce hospitalizations and improve both symptoms and exercise tolerance. However, it again does not have a mortality benefit. However, you guys have probably noticed we have several patients admitted with digoxin as a home medication. So that is important to remember, because a lot of our new data, even published within the last year, has shown that patients can clinically deteriorate if the medication is abruptly withdrawn. And some of the newer data shows that there potentially could be an increase in morbidity and mortality from withdrawing these patients even up to a year's time out. So it does potentially play a role in patients that have concomitant AFib. So that is something to consider as this role. Okay, so moving on to brief clinical pearls here. It is a cardiac glycoside, so it's going to help decrease some of our heart rate. It has a very narrow therapeutic index, so a lot of times we're looking at digoxin levels for monitoring. We want to keep it less than 1 to avoid toxicity. So if patients have an acute kidney injury or hyperkalemia that may indicate or lead to signs of DIG toxicity, which are nausea, vomiting. You may have CNS effects, and then potentially bradycardia or heart block is what we want to avoid. So for patients that have severe toxicities, we do have an antidote available, Digibind. So to reduce our risk of toxicity, we're going to monitor renal function, heart rate, and EKGs as indicated, making sure that our electrolytes are optimized, watching for signs and symptoms of toxicity, and checking levels and avoiding drug interactions as indicated. So this is more pulled from our guidelines. It gives kind of a stepwise approach for how we add on agents. And it's going to be very patient specific, which agents we're going to add on in certain patient populations. So I'll let you guys kind of look at that on your own time since we're running short on time. And then finally, I just want to briefly touch on some of the new therapies that have come out even within the last year. So our SGLT2 inhibitors are empagliflozin, canagliflozin, and dapagliflozin, and these work on the sodium glucose transporter and inhibit sodium reabsorption and increase glucose excretion. So it's got a number of proposed benefits in heart failure, potentially decreasing preload and afterload and decreasing cardiac remodeling. We do know that these have a cardiovascular benefit with its labeled indication in patients that do have diabetes, and that is seen in the EMPA-REG, CANVAS, and DECLARE trials, where they had about 10 to 15% of heart failure patients, and they found relative risk reduction in heart failure exacerbations in these patients. However, the question has now come up recently is, do these agents confer a benefit without the concurrent diagnosis of diabetes? So that's where we had these new trials, so the DAPA-HF and EMPEROR-Reduce that came out within the last year, looking at dapagliflozin and empagliflozin compared to placebo. All of these patients had either a heart failure, reduced ejection fraction less than 40, functional classification 2 through 4. They were on guideline-directed therapy, and important things to consider here is that less than half of the patients had diabetes in these groups. So we do have about half the patient population that were heart failure alone. Most of these patients, if you look at the baseline demographics, they were on optimized goal-directed therapy with ACE/ARB or ARNI plus a beta blocker, and compared to the Paradigm trial, we have more ARA use, from 50% up to 70% in these trials. Further outcomes, just to highlight the big ones here, in both of these trials, we saw the composite endpoint of cardiovascular death and heart failure hospitalizations be significant, with relative risk reductions of 25 to 26% in both of the groups. With dapagliflozin, we actually saw each of the mono groups, heart failure hospitalization and CV death alone, kind of meet that mark for superiority. However, it did cross the confidence interval for CV death with the EMPEROR trial and empagliflozin. So that's important to remember here, is that we have more data now to show that these may be beneficial in patients without diabetes from a heart failure perspective. So subgroup analysis, again, we see in our patients with or without diabetes, this effect still stood from a CV death and hospitalization benefit. ADRs, again, here were no different between the group. We do know there are some risks with SGLT2 inhibitors, but none of these were statistically different in any of the trials. So looking at some of our indications here, empagliflozin is indicated still to reduce CV death in patients with diabetes plus CVD. Dapagliflozin has heart failure indications here, so patients with diabetes and risk factors, so ASCVD risk factors, it can potentially reduce heart failure hospitalizations. But as of May of 2020, it got a new FDA indication to reduce CV death and heart failure hospitalizations in patients with reduced ejection fraction with or without diabetes. So this was kind of groundbreaking information that we have a new indication with the SGLT2 inhibitors, specifically dapagliflozin. Canagliflozin also has some potential benefit with heart failure hospitalizations in patients with diabetes and diabetic nephropathy with albuminuria, as well as its other indications that are FDA approved. So kind of wrapping up with these are, we want to consider renal function. All of these right now are contraindicated in creatinine clearances of less than 30, but there may be some dose reductions, specifically with canagliflozin that we saw in the Credence trial. It may confer a benefit from renal protective perspective. Some of the pros with these agents, they actually are minimally hypoglycemic and actually can lead to some weight loss, which may be beneficial for some of our diabetes patients and even heart failure patients. But we want to weigh that in relationship to some of our adverse drug reactions. So the low risk of euglycemic DKA, it can potentially lead to volume depletion, which may come into play with some of our heart failure patients. So it has been theorized different strategies for managing diuretics for these patients that are started on SGLT2 inhibitors, potentially decreasing the dose. I think that's still up to considerations and we need more information on. And then obviously some of our risks with genitourinary infections and hypotension. They do come with a black box warning with lower limb amputation, but some of our newer data has not really shown some of these risks, specifically statistically different between placebo-controlled arms. So some things that we're still left to question are, where do we add this in our role of therapy, and is this a class effect? And so this, hopefully when we have updated heart failure guidelines, we'll get more information for what patients are most appropriate to add these onto. And just for your guys' information, recently passed on P&T, we did add the indication for dapagliflozin for the heart failure indication as of July. So it can potentially be prescribed and added to your patients that have an EF less than 40 and a creatinine clearance greater than 30 plus or minus diabetes. And then finally, this will be very, very quick. So vericiguat is a new medication that is not yet FDA approved. It works to increase nitric oxide production via stimulating the soluble guanylate cyclase. It can increase the GMP pathway and potentially reduce myocardial dysfunction and vascular dysfunction. This came into play and because of its potential benefits in heart failure with the Victoria trial. So they randomized this drug compared to placebo in about 5,000 patients with a follow-up time of around 11 months. Patients were included if their EF were less than 45. They had evidence of worsening heart failure and they fell within functional classes of 2 to 4. They excluded patients that would be at risk for hypotension via drug interactions or low systolics. For baseline demographics, they were relatively similar to prior studies, except for the fact that they had a much higher patient population with functional classification 3, so more symptomatic patients of up to 40%. So this is potentially a sicker patient population. For outcomes, they did find a statistically significant difference with a relative risk reduction of about 10% in favor of the vericiguat group for the composite of CV death and heart failure exacerbations, and a number needed to treat of 34. Again, like I mentioned, this was potentially a sicker patient population, which may be related back to the overall higher incidences of some of the composite outcomes. And then important to point out here is that there was no statistically different findings as far as hypotension and syncope, which would be something that we're thinking about for our mechanism of action here. So here's a summary of some of our newer trial data that includes our Entresto trial, our SGLT2 inhibitor trials, and our Victoria trial with the vericiguat. I've highlighted the key differences here, some of their baseline medications, which may come into play for how potentially these medications may or may not be added on down the road. So as you can see here, I've kind of talked throughout the differences here. Victoria had potentially a sicker population. DAPA and Emperor had higher rates of the ARAs compared to our paradigm trials, same with Victoria. And you can kind of see overall their relative risk reductions across the board for the composite output at the end. So in summary, some things to consider here when we're thinking about heart failure treatment as a whole is that we want to always add our ACE-ARB, potentially switching to an ARNI as well, and then beta blocker for first-line therapies. You want to consider titrating to the max tolerated dose, potentially every 2 weeks or faster, inpatient if you're able to monitor. Patients should be prescribed diuretics to help with symptom control, and then you want to start evaluating for add-on therapies to further reduce morbidity and mortality based on patient characteristics. And then finally, some inpatient considerations is that goal-directed therapy should be continued inpatient as long as there are no contraindications to care and the patient is hemodynamically stable enough to maintain that regimen. You always want to ask about adherence and cost to make sure that there are no barriers to care and there's something that we can do to help prevent future exacerbations. While on the inpatient side or even in clinics, you can help optimize these by titrating doses and ensuring adequate follow-up. You want to make sure that we are monitoring electrolytes, renal function, heart failure, and their blood pressure. And additionally, you can monitor their B-type natriuretic peptides if they're in for a heart failure exacerbation to see if it's declining, to see if they're ready for discharge. We always want to manage their comorbidities based on guideline recommendation, and then education is key. These patients are on a significant number of medications. They may get really confused for what is taken when and why they're on these, so readdressing the importance of these medications, how to take them, considering cost and adherence will help make sure that these patients are optimized, they're able to take their medications, and there are no further gaps in their care.